First adjustment I'm going to start off with the foot ankle is the P to A of the subtalar joint. In other words, the calcaneus can't move from posterior to anterior on the talus. So our patient's supine, the knee is supported by the patient's foot being underneath. And doctors, this is really just like the assessment. All right. As a matter of fact, I forgot to show this assessment earlier. So what this assessment looks like is this. We're on the calcaneus. We make a forearm contact on the bottom of the foot to to dorsiflex the ankle. We have a little bit of eversion of the calcaneus as well. We place our thumb index web on top of the talus. We push anterior to posterior on the talus as we lift up on the calcaneus. So the talus is moving backwards on the calcaneus is moving forwards towards me on the talus. So that's our assessment. You should feel some give there. If that give is lacking, you're just adding a thrust to the assessment. All right? And make sure that your hand's not underneath the heel, because you'll end up hurting your hand if you have your heel. If you have your hand underneath, you'll end up squashing your fingers. So make sure you leave a little bit of opening underneath. So again, here's the contact, thumb index web on the talus, some dorsiflexion at the ankle, some eversion of the calcaneus, and you're lifting with my left hand, pushing down with my right hand, and thrust into the board. And that can be done a couple, 3 times. If you want to, you can do this with a little momentum as well. So what I'll do is set up the adjustment the same way. Lift up, push down, dorsiflex, evert, and then slam it into the board. And a couple, 3 times of that will work pretty well also. All right. While we're here, let's have you bend this and let's straighten that out. Let's see if we still have a good camera shot here, and we do. So I'm going to show you the anterior to posterior and the posterior to anterior ankle mortise adjustments, which again are just like the assessments. We can zoom in on this a little bit. All right. We're going to start off with the hip at 45 degrees, the knee at 90 degrees, and the speed of board is going to be set medium tension. Just hold your leg right there for me. There you go. Place the heel over the open wedge. Have the patient stabilize their own thigh. Just have them hold that hip at 45 degrees, the knee at 90 degrees, and have the foot in a neutral position, halfway between dorsiflexion and plantar flexion, nice and neutral. My thumb index web of my inferior hand is on the talus. My thumb index web of my superior hand is on the distal tib fib. I'm actually going to increase my tension a little bit because I do need to load this up a bit. So I increase my tension. I lean such that my thrust is going to be parallel to the joint, right, through the joint. So I lean into this a bit, and the thrust for the anterior to posterior is going to be through my superior hand, right? And that can be done 2 to 3 times. If I want to target the opposite movement, the posterior to anterior of the distal tib fib on the talus, what I'll do is I'll stabilize the leg rather, with my thigh. The contacts are the same, but now I'm pulling up with my right hand and pushing through the talus with my left hand. Again, the tension is set relatively high. All right. I load it up with the tension I just described, and then thrust through the inferior hand, which in this case is my left hand. So I stabilize against my own thigh, the patient's leg against my own thigh, have a good grip on the distal tib fib. I pull up on that with my right hand. I push down through the joint line with my left hand, and then add my HVLA to that. Okay. For long y-axis of the mortise and long y-axis of the subtalar joint, right, I can accomplish this with a index contact right on top of the dome of the talus, right? My outside hand is going to contact the calcaneus and the heel cord, the Achilles. I'm going to maintain some dorsiflexion in the ankle, lean back a little bit, stay in close but lean back a little bit. I'm not going to have my patient hold on, so rest your hands on top of on the sides there. And the reason I don't want him to hold on is because I want him to be able to move. I don't want to pull the hip out of its socket, and I don't want to put any stress into the knee. A little bit of internal rotation will close pack those joints, the knee and the hip a little bit, maybe about 30, 40 degrees of hip flexion. Lean back a little bit and just add a little bit of a thrust to open that up nicely. Okay, that would be for the mortise. If I wanted to stress the subtalar joint, I'm just going to do it's going to look almost the same, but I'm going to stress the contact on the calcaneus instead. So I'm going to get a nice grip on the calcaneus, a little bit of eversion, right? I'm going to stabilize the talus, and my thrust is going to be mainly with my right hand in this case. Again, I'll internally rotate a little bit, close pack it. I want the patient to be able to slide down, and I thrust mainly with that hand, letting the other hand come along for the ride. This is for a lack of upward spin of the cuboid, right? The setup for this is critical. It's a great adjustment for this particular restriction, but you've got to follow the steps in order to have it be effective. The heel has to be off of the speeder board, and the open wedge has to be facing cephalward. Right? You're going to take your inferior hand and you're going to place your middle digit under the foot so it actually is on the cuboid underneath the foot. And then the rest of your hand is going to wrap around the dorsum of the foot so you can hold the foot on the speeder board. All right? So you want the tension set relatively high because you need to press down into this. And this is going to always work best when you're on the opposite side of the table from the contact. All right? So the rest of my hand's pushing the foot down. My middle digit is underneath the foot on the bottom of the cuboid, and my other hand is going to take a thumb index web over the talus. Right? So the talus articulates with the calcaneus, calcaneus with the cuboid, and indirectly you'll be shearing the talus and calcaneus backwards as you lift the cuboid up. To accomplish that, I'm going to have my patient gently start to bring their knee out. And he'll start to appreciate that that's really loading up my digit on the bottom of his foot as he does that. All right? So the thrust will occur while he's starting to do that. So starting back from the beginning, the heel's off the board. Middle digit is underneath the foot on the cuboid. I'll lift you up here again for a second so I get that little better grip there. The rest of my hand is holding the foot down on the board. All right? My superior hand is making a contact over the talus, and I'll have my patient very slowly start to bring that leg out, and then I load it up through the superior hand. I thrust through the superior hand. So again, middle fingers underneath, fingers wrapped around. Bring this back to the center. Get on the talus with the superior hand. I have this set pretty high because I'm leaning into it. I'm holding the whole foot flat with my hand. I get onto the talus. I have my patient slowly bring their knee out. It loads up my digit, and I give it a nice HVLA through the talus, which brings the cuboid up. The adjustment for the downward spin is done in the supine posture. I'm going to position the foot so that it's relatively neutral on the board. All right? Tension set up pretty high, right? Because I want to be able to lean into this, right? And I'm going to find the cuboid right behind the styloid. I'm going to make a hypothenar contact right on top of it. Okay, strong hypothenar contact right on top of the cuboid. My other hand is going to wrap around the inside of the foot, and my thumbs are going to cross. It's set relatively high so that I can lean into this. And actually, I'm going to have to set it higher than that. Okay, so again, I'm using a soft hypothenar contact on top of the cuboid. Going to roll in with a good tissue pull on top, Going to reinforce on the inside of the foot with my other hand. Going to lean in, lean in, lean in, and then thrust down through the cuboid. All right, you okay? So again, I recocked it. Lean in, and then thrust. 2 to 3 thrusts will usually suffice for that. So I'm going to use a double thumb index contact to grab onto all the tarsals on the inside of the foot. All right? And for our upward spins, I'm going to place the foot in a position of dorsiflexion eversion. Dorsiflexion eversion. I'm going to stabilize proximally while I move the foot through a figure 8 motion distally, with the foot in this dorsiflexed and everted position. It's actually a powerful mobilization. You want to just keep that figure 8 going on until you feel better movement and then move on to the next segment. So you're doing the talus, navicular, navicular, cuboid, cuboid, first metatarsal. So move that down again, maintain it in that dorsiflexed and everted position, and from there create your upward spin using that figure 8 movement. Cuboid, first metatarsal, bring it up and get that nice figure 8 moving. Nice figure 8 movement. For the downward spins, we're going to plantar flex and invert, right? We're going to stabilize proximally, and we're going to move things around distally. Just maintain the foot in that plantar flex and inverted position, and start with your figure 8s. Start at naviculotalar, then navicular cuneiform, and then cuneiform metatarsal. Sometimes you'll feel some nice crunchiness as things start to move a little bit better. This is a toggle board adjustment for inversion, eversion of the subtalar joint. The hip will be flexed and abducted about 45 degrees. The knees at about 90 degrees. The foot and ankle are resting on the speeder board with the speeder board nice and even right up the thigh, right up the leg. The doctor is going to support the patient's thigh against their knee. He's going to grab the talus and then grab the calcaneus with the other hand. You want to stabilize the talus and move the calcaneus on the talus. So for the eversion, I'm going to place the subtalar joint in eversion. Here's the movement. Hold the talus firmly and slam it into the board. I'm going to use my own thigh as a fulcrum for this. So there's the movement again. This is a very common restriction. Strongly evert. I'm doing this with my hands. I'm holding on to the talus very firmly as I slam it into the board using my own thigh as a fulcrum. Now for inversion, you want to be real careful because this kind of mimics what? Mimics like an inversion sprain, right? So it's very important to hold on to the talus because you don't want to stress those lateral ligaments. So I grab the talus, I'm pulling up on the talus. Grab the calcaneus, I'm pulling up on the calcaneus, I'm holding the talus very firmly so I don't get that sprain of the lateral ligaments and slam it into the board. Using my thigh as a fulcrum. Pull up on the calcaneus, hold on to the talus very firmly, and slam it into the board. A couple, 3 times does the trick. The patient with a very high stiff arch when we did the second cuneiform squeeze. So the knee is at 90 degrees, the hip is at 90 degrees. Just maintain that position right there. So remember for that, we're going to just make that contact right over the row of cuneiforms with our middle finger over the transverse arch. We're going to come up on the outside of the foot and we're going to do that squeeze to do the assessment. For an adjustment with a person with a really high arch, we can just bring the heel to our own knee, squeeze, and then just a little bit of a thrust will kind of give you that pliability, some of that pliability back. Another variation of this same adjustment, you've probably all seen this before, is to grab that transverse arch with that middle finger, wrap it around with your other digit, dorsiflex the ankle, again internally rotate a little bit to close pack everything, give a pull down, and then just a nice impulse towards you will usually give you a nice increase in pliability in that arch as well.